Hi everyone, I'm Andrew Guyman. I'm a fourth year medical student at USD. We're continuing with our USD Anesthesiology 101 lectures. We're on day 4 discussing intravascular fluids. So to begin, we'll just discuss how to use an IV, how to assemble and prime a fluid set, pushing medications, things along those lines. So when you're assembling and priming a fluid set, there's two essential components. One is your fluid bag, and then the second is your tubing. So we'll go through just your tubing. You would receive this from somewhere around the nurse's station. You'd open your bag and you would have something looking like this. At the top, you have a trocar. Then you just have like a cap that protects the trocar. A drip chamber here. So your fluid bag would be up here, and then you would have fluid that's dripping into your chamber. It would run down through your line, and then you have a flow controller here with a little dial. So as you slide this dial down, that's going to apply pressure to your tubing and reduce the flow of fluid going through your tubing. You have an injection port over here that you could administer meds through or flush the line through, and then your connector piece and hub that protects that. So to assemble this fluid set, all that you would do is you would grab a bag of fluids like this. You would grab your tubing like this. On your fluids, it's not shown here, but initially there would be a blue cap on this piece right here that they're pressing the trocar into, and you would peel that blue cap off. You'd take the cap off of this trocar as well, and then you just like firmly press the trocar up into the fluid bag there. This port right here is to administer medications through, so that's not going to accept the trocar. You're going to need to make sure that you're pressing the trocar up through in the acceptor site that had the blue cap on it and that fits the trocar appropriately. Then you would squeeze this drip chamber, and then as that reinflates, it's going to provide suction that's going to draw the fluids down into the drip chamber. And then you wait, maybe 30 seconds or so as fluid begins to flow through the line until it flows all the way through the line. Watch for bubbles. As soon as you see that there's not too many bubbles left in the line, then you can clamp. Right here would be a clamp. You can clamp your tubing and stop the flow through the line. So the whole purpose was, 1, to get the tubing attached to the fluid set so it's ready to go, and 2, to remove the air from the tubing. Then say you're ready to push a medication, so you're in the OR and maybe you're inducing the patient, and your attending says, hey, would you push propofol or would you push lidocaine? What you'd do is you would take your syringe and you would find this injection port. So this is going to be near the patient's hand. You would attach your syringe to the injection port and push the medication through. One thing that's important is these injection ports are considered like sterile. So in theory, you don't want to have any bacteria that's on the injection port that gets pushed into the patient's bloodstream. So before you push the medication through, you would take a little alcohol wipe and you would wipe down this adapter piece. If you wanted to flush a medication, it'd be the same thing. You would take like a 5 or 10 cc flush, wipe down this piece, attach it, and then push the saline through there. That could be beneficial in a few different situations. So you might flush your medication through here before you deliver a medication if this line wasn't running. So maybe more in the inpatient setting, if they just had an IV in place, but this wasn't running, then you might flush medication through or flush saline through first to ensure that your IV is still properly placed, that it hasn't infiltrated. And then if you're able to do that, then you could push your medication through afterwards. Most commonly, you're going to see flush after you push medication through. So say that you just push medication through, but the medication could be sitting in this portion of the tubing. So then afterwards, you would take a 5 or 10 cc saline flush and you would push it through afterwards to push this all the way into the patient. When you're pushing medication or flushing medication, a nice little trick is making sure that you're clamping upstream or kinking the tubing upstream. So if you're giving medication, you want it to get over here to the patient. You don't want your medication to flow back upstream into the tubing. It would just delay it getting to the patient. So what I see most anesthesiologists do is when they're pushing a medication through, they'll grab the tubing right here, form a little kink in it, and then they know that their medication is going in this direction. Finally, we're going to discuss the different components of an IV kit. So you've got to a point where you've assembled your fluid bag, and then a nurse says, hey, do you want to start an IV? And you say yes. So you'll grab your assembled fluid bag, you'll grab an IV needle and catheter, and you'll grab an IV kit. What you'll find in the IV kit are these components. So you have a tourniquet, you have a tegaderm, some gauze, some like labeling equipment, tape, and then disinfectant. How I would normally go about approaching this is making sure you're just set up for success from the beginning. So walk into the patient room, introduce yourself, go ahead and hang the fluid bag up, and make sure that you have easy access to the distal end of the tubing because you'll need that after you start the IV. Take your tegaderm and peel off the paper on it and lay it with the sticky side up. That way you're ready to go. Take your tourniquet and place that around the patient's arm, and then take your disinfectant over here and begin disinfecting over the top of any potential veins that you're considering to use for IV access. A nice little trick is when you're using this disinfectant, if you're a little bit rough as you disinfect, you can sometimes use that tactile sensation to stimulate the veins and get them to stand up and become more visible. Then you would place your IV catheter into the patient and secure it with the tourniquet and with your tape and go from there. Unfortunately, sometimes after you go through all the work to start an IV, the IV can infiltrate. Infiltration, by definition, occurs when the medication or fluids that you're administering through the IV, instead of going into the intravenous fluids, they're going into the extravascular space. So that could happen for a number of reasons. Perhaps when you went to place the IV, you blew through the back wall of the vein. And then when you go to deliver your fluids, those fluids would be going into the extravascular space. You could shear the vein when you're placing the IV. And then you could also have like the catheter on the IV slip backwards out of the vein after you've already successfully placed an IV. Regardless of the cause, it's important to know how to recognize and manage it. Ideally, starting with knowing how to prevent IV infiltration in the first place. So, probably, the first step is making sure that you've properly placed the IV. And that covers a couple different things. So, say if you're struggling to place an IV on a patient, then maybe you would need to use ultrasound to ensure that you're able to get it placed appropriately. If you're still struggling, ultrasound isn't working, you've already infiltrated a couple when you've attempted to place them, then you might also need to try placing more secure or obtaining more secure intravenous access. So that could be like placing a central line if you're really struggling. Important if you're concerned about IV infiltration to make sure that you're using veins in fixed regions. So an IV on the back of the hand or in the wrist or in the antecubital fossa, where there's like joint spaces or room for movement within the limb, are more likely to infiltrate because of that movement, rather than placing an IV somewhere on the shaft of the forearm. And then finally, making sure that you secure the IV well. So that's with your tegaderm and your tape, trying to limit the amount of play that the catheter has within the vein or on top of the skin of the patient. There's a few different ways to recognize IV infiltration. So in the area surrounding the IV, you could see edema, blanching. Patient might report pain or tightness. Or if the infiltration is severe, it might get reduced blood flow or almost like a compartment syndrome in the limb. So coolness. And then two different tests that you could do to check and see if the IV is infiltrated. So one would be aspirating. If you aspirate on a properly placed IV, you should get return of blood flow with very little resistance. If it's infiltrated, you're unlikely to get good return of blood flow. Another aspect is generally, if your IV infiltrates, you would see a decrease in the drip rate or the flow of fluids. However, to double check that, you can do what's called like a tourniquet test. So whether you place a tourniquet or if you just use your hand to occlude the vein that's upstream of the IV, we'll call this the tourniquet test. If you occlude the vein that's upstream of the IV, you should see a reduction in the drip rate because no blood is flowing through that vein anymore. So the fluid that was flowing in there should also stop as well. Once an IV infiltrates, the first thing that you want to do is stop the infusion. So this is important, especially if you're infusing a medication into an infiltrated IV rather than just running a fluid drip. Many infusion pumps will continue to pump the medication into the infiltrated IV even after it's infiltrated, regardless of the increasing pressure that's accumulating within the extremity. So this could lead to like a compartment syndrome because you're increasing the pressure in the extremity and could impede distal blood flow past the infiltration site. Kind of likewise with this, you're going to want to disconnect the IV tubing. But importantly, you're going to want to leave the catheter in the infiltration site. So the reason that you leave the catheter in the infiltration site is because for some infiltrated IVs, for example, vasoactive medications, classic example would be phenylephrine. Those have specific antidotes to treat the infiltration that occurred. So phenylephrine would cause severe vasoconstriction, and that can cause necrosis at the site or distal to the site. So it's important to leave that catheter there so you can administer the antidote, which in that case would be phentolamine or terbutaline or nitroglycerin, to try to relieve that vasoconstriction that the phenylephrine was causing. And then finally, you could try warm or cool compresses, and then like massaging the infiltration site and elevating the site, all trying to keep the pressure swelling to a minimum. So when we consider infusing fluids into the body, it's helpful to consider the concept of total body water. Now this shows that we have about 55% of the water in our body within cells and 45% outside of the cells. 20% of our total body water is in the interstitial space, and then about 8% is in the intravascular space. Now, there's 2 points that I want to make. One is concerning the infusion of crystalloid fluids. So when you administer a crystalloid fluid, so that's going to be water and electrolytes, there's no barrier that prevents the electrolytes from crossing the vascular membrane. That means that because the electrolytes in the water can both cross the vascular membrane, when you infuse that crystalloid solution, very quickly, most of it is going to diffuse into the interstitial space. So, say you give a liter of fluids, well, you're not actually going to see that response of the patient now having a liter more blood or pressure within their vascular system because much of it diffused. Nothing stops the diffusion of the electrolytes across the vascular membrane. The electrolytes don't exert any oncotic pressure within the vascular system. Now, just to contrast that to when you give, say, hypertonic saline or hypotonic saline, between the extracellular space and the intracellular space, they definitely do cause an osmotic pressure. So your electrolytes are not able to freely flow across the cell membranes. So that's why if you give too much hypotonic saline, you could be at risk for rupturing cells and causing disability. Same thing with, or the opposite effect with hypertonic saline. So your crystalloids, they still will have an effect between the extracellular and intracellular space, but just not between the intravascular and interstitial space. Now, contrasting that with colloid solutions. So colloid solutions are a suspension of some large molecule, generally albumin, which is a large protein. And when you administer that into the intravascular space, the idea and what normally happens is those proteins are trapped within the intravascular space. They exert an oncotic pressure that draws water either in from the interstitial space, or it just maintains the water in the solution that you had administered with the albumin. It maintains the colloid solution within the intravascular space. So then you might see a more appreciated response in blood pressure or a patient's volume status because you're maintaining the volume within the intravascular space. The last point that I would like to make with that is there's some conditions. The classic example is sepsis, where you get very permeable vascular membranes. And when that occurs, the albumin is able to diffuse across the vascular membrane, and then you see less of a benefit when using albumin in that state because it's now not able to exert the oncotic pressure within the vascular membrane that was the major benefit of using it previously. So the first type of fluid that we'll talk about that can be infused intravascularly are the crystalloid solutions. So that's going to be normal saline, lactated ringers, and then plasmolite. When you're classifying crystalloids, there's two different ways to look at them. So the first is going to be composition, and composition is referring to balanced versus unbalanced crystalloid solutions. Balanced crystalloid solutions have a composition that mirrors that of plasma. So that would be like plasmolite is a really good example, but lactated ringers also is pretty close. So you can see over here in the plasmolite example, you have sodium level that's more close to the physiologic level in plasma. Same with potassium around 5. And then it also has magnesium in it as well, a chloride level that would be within the normal range. Osmolarity that's more similar to that of plasma. You can see that lactated ringers is a little bit closer to what you would see in plasma, and then normal saline is the most unbalanced. The second way that you can classify crystalloids is going to be by tonicity. So that includes or refers to hypotonic versus hypertonic solutions. Generally, this is used to classify different types of normal saline between hypotonic, ones that have less electrolytes than what you would see in plasma, versus hypertonic solutions, which have more electrolytes than what you would see in plasma. The last aspect of crystalloid solutions that we're going to look at is the strong ion difference. Strong ion difference is a simple calculation that looks at the difference in charge between the strong cations. So that would be sodium, potassium, calcium, magnesium, and the strong anions, which would be chloride and lactate in the crystalloid solution. So in plasma, the difference between these ions is around 40, and in normal saline, the difference is 0. Anytime that you're infusing a solution with a lower strong ion difference than plasma, that'll lead to a metabolic acidosis. So this is what you can see when you're infusing normal saline, and the idea is when you infuse normal saline, which is 0.9% sodium chloride, you're putting in a ton of chloride into the patient, and then that's displacing the bicarbonate that's in there because they both have this negative charge. So when you increase this, you're decreasing your bicarbonate, and because this is a base, then you're decreasing a base, and you can cause a metabolic acidosis. And that's according to the strong ion difference principle. So the most clinically significant change in electrolytes that you can see with running normal saline for too long of time is an increase in plasma potassium. Then, like we just talked about, because of the 0 strong ion difference in normal saline, that can result in metabolic acidosis. You can get a dilutional coagulopathy because you're diluting out your coagulation factors. And then, kind of from what's theorized, increase in chloride that can result in kidney damage. So balanced crystallides generally include Ringer's lactate and Ringer's acetate gluconate, which is referred to as plasmolite. Balanced crystalloids contain different amounts of electrolytes to mimic the plasma concentration. Now, because of this, they also contain an anion buffer to maintain the electroneutrality of the solution. So that's going to be lactate in Ringer's lactate or acetate gluconate in plasmolite. That's a good thing because it increases the strong ion difference closer to the physiologic level of 40 that you see in the plasma. And when you have a strong ion difference that's close to the plasma level, that reduces your chance of accumulating a metabolic acidosis, like you see with normal saline. However, there's concern that these anion buffers can accumulate with prolonged infusion, and when they accumulate, they've been shown to cause hypotension, decreased cardiac contractility. And then there's a particular concern with plasmolite. Plasmolite has acetate as one of the anion buffers, and acetate chelates calcium, and therefore reduces the plasma concentration of calcium. So if you're ever performing a plasmolite infusion, you want to be monitoring your ionized calcium levels as you do that. There's two other crystalloid solutions that we'll talk about, the first being hypertonic saline. Hypertonic saline is used in two situations, the first being when a patient has an intracranial hypertensive emergency or increased intracranial pressure. The hypertonic saline draws fluid out of the cells that are in the brain and then into the vascular space, And then the water, the fluid that's drawn out, can be redistributed systemically throughout the body, so it helps to decrease the intracranial pressure. The second time that you would use hypertonic saline is if a patient has acute symptomatic hyponatremia. So, right, hyponatremia. The key part of it here is acute symptomatic. So if a patient is mildly hyponatremic, you're not going to use hypertonic saline. It's only if it's a very serious situation. There's two different side effects to be aware of with hypertonic saline. The first being, and it just makes sense, but hypernatremia. And the second being peripheral vein thrombophlebitis. Peripheral vein thrombophlebitis. The main indication for 5% dextrose is to replete a dehydrated patient or a hypernatremic patient's water if they're unable to receive enteral water. So if they can't receive water by mouth, then you would offer 5% dextrose. The dextrose is metabolized immediately, so you're really just replacing the patient's water. And so the main indication is for hypernatremia or dehydration if they can't receive water by mouth. And then you're going to have two different side effects to be aware of. The first is hyperglycemia because of the dextrose. And the second, hyponatremia, because this is really a hypotonic solution, especially after the dextrose is metabolized. Colloids are solutions that contain substances with large molecular weights, such as albumin or synthetic starches, so those would be synthetic colloids. Because they have these molecules with large molecular weights, those molecules are trapped intravascularly, and these then maintain an oncotic pressure within the vascular system, which pulls water or prevents water from diffusing out of the vascular system. So they're expected to maintain a larger intravascular volume and maintain that volume for longer. Likewise, you could use a smaller volume of colloid solution to maintain the same amount of intravascular volume. One caveat to this is during critical illness, a good example is sepsis. You have increased vascular permeability, and then this advantage can be lost because the albumin or the synthetic starches are then able to leak across the vascular membrane, and that eliminates the oncotic pressure that draws fluids into the vascular system. So there's a lot of debate on when to use colloid solutions versus crystalloid solutions. There was several studies that looked at albumin replacement compared to crystalloids in critically ill patients, and they didn't find any mortality difference, although there was a lower mortality rate observed in a subgroup analysis of patients with septic shock. And there's a randomized trial ongoing to see if albumin is better if it provides a decreased mortality rate in patients with septic shock. That said, the Stanford CA1 manual recommends using colloids in several different situations. So the first is being if you are expecting to replace over 3 to 4 liters of fluid, then you should consider giving a colloid solution. So indications for colloids, the first being if you're expecting to give more than 3 to 4 liters of fluid, then you should consider a colloid. The half-life, so how long these fluids are going to maintain that intravascular volume, is about 3 to 6 hours for colloid solutions versus 20 to 30 minutes for crystalloid solutions. So you can really see the benefit of having that increased oncotic pressure to extend the duration of the increased intravascular volume. The second indication would be in patients who have large protein losses. So if they're already low on albumin or they have some reason that they would lack in oncotic pressure, they would have a deficiency in that already, then you would consider giving a colloid. So this would be cirrhotic patients and burn patients are two good examples. Third example, for any patient in hemorrhagic shock when blood is not available. Blood would be ideal, but if that's not available, then you would replace 1 cc of blood loss with 1 cc of colloid. And then the last example is if you were concerned about volume overload. So two examples of this would be if you were concerned for pulmonary edema or bowel edema. The most common colloid solution that you'll see is albumin. It comes in 5% or 25% solutions. The 5% solution is used to treat hypovolemic patients. The 25% solution is used to treat hypovolemic patients that are fluid and sodium restricted. So 5% is going to be a little bit more common in practice. The big drawback to albumin is it's derived from pooled donated blood, so it's expensive, especially compared to normal saline. However, albumin makes up 70 to 80% of the plasma oncotic pressure naturally. So it's going to be the most physiologic colloid solution, or integrate the most easily with the natural oncotic pressure that's provided by the vascular system in the body. Because albumin is expensive, we've tried to develop synthetic colloids that are available at a cheaper price than albumin. So synthetic colloids include large molecules with a base structure of like starch, dextran, or gelatin. One of the most common ones is the hydroxyethyl starch, HES. These have large molecular weights, so the idea is they can maintain an oncotic pressure in the vascular system similar to albumin, but there's been multiple studies that have found side effects or some concerns with the synthetic colloids. So in critically ill patients who were given the hydroxyethyl starch colloid, there was an increased mortality and increased renal injury compared to the use of crystalloids. Another study found that there was an increased risk of developing AKI, acute kidney injury, in patients who received HES. There's an increased risk of anaphylactoid reactions and an increased risk of postoperative coagulopathy. This was attributed to the synthetic colloid HES interfering with von Willebrand's factors and impairing platelet function. Overall, there's definitely some hesitation with using synthetic colloid solutions because of all of these side effects. So the last concept that we're going to talk about is the idea of maximum allowable blood loss. This is referred to as MABL, and traditionally there's an equation that can be used to calculate the maximum allowable blood loss. I wrote that down here at the bottom, so that's going to be equal to your estimated blood volume, total blood volume of the patient, times the patient's hemoglobin minus the minimum acceptable hemoglobin, so that's something that you'll determine clinically, divided by the hemoglobin of the patient. I think probably the easiest way to understand this concept is just to work through an example. The reason that we have an equation to determine the maximum allowable blood loss is, say that you're in the OR and you have a patient who's bleeding. Well, the first thing that you're going to do is you're just going to generally administer crystalloid or colloid fluids to try to maintain the intravascular volume. However, you can't do that indefinitely because ultimately you're diluting your red blood cells and your coagulation factors, and that's going to inhibit your ability for your blood to deliver oxygen to your vital organs. So at some point, you're going to have to switch from crystalloid fluids or colloids to administering blood. And then this equation that we have here is trying to help guide at what point do you begin administering blood. Well, traditionally, there's two different lines of thought when you're practicing transfusion medicine. So one is practicing medicine transfusion conservatively, and the other is liberally. So are you going to transfuse blood early or late? The majority of the literature, according to the Baby Miller textbook, says that you should be a little bit more conservative in when you begin to transfuse. So that would be like transfusing when a hemoglobin level, your minimum acceptable hemoglobin level, is less than 7. More liberal transfusion would be transfusing when your hemoglobin level is less than 10. However, there's definitely that gray area in between that requires a lot of clinical judgment and expertise. And then the last note that I would add to this, when I was discussing it with Dr. Iverson at Sanford, he said, so first, your patient's bleeding, you're doing crystalloid fluids and colloids. Then once you reach the threshold that we'll calculate here to decide when to transfuse blood, then you begin transfusing blood, and then you're guiding your transfusion on how much you give via like following your lab values. So a CBC and trending the hemoglobin and the hematocrit and going from there. So finally, to get down to the nuts and bolts of this, how do we calculate this? So we'll work through an example. So we have an 85-year-old male. He's undergoing a CABG. He has a history of coronary artery disease, 2 previous MIs, and then he has a pre-op hemoglobin of 15, a BMI of 30, and then a weight of 100 kilograms. The reason I chose this vignette is I think it just illustrates the point of incorporating the clinical judgment that you have as an anesthesiologist into when you're going to transfuse. So because this patient is definitely higher risk for ischemia and they're undergoing a surgery that you're definitely anticipating some significant blood loss, you would have a more liberal tendency to transfuse earlier because you don't want to put them at even more increased risk for ischemia, and you know that there's a high risk that they'll continue bleeding. So now we're taking this vignette, we're applying the maximum allowable blood loss formula. So the first thing that we're faced with is calculating the estimated blood volume of the patient. That's the total blood volume. To calculate that, you're going to need some sort of a chart like I have over here. And what you're going to do is find like the criteria that fits this patient. So the estimated blood volume of a patient depends on a few things. One is the sex of the patient. So this is a male. Another is the age. He's 85, so he's definitely an adult. And then also the BMI of the patient. I said he has a BMI of 30. So we're going to be using this criteria right here. And it says that to calculate the estimated blood volume of the patient, that's going to be 60 milliliters per kilogram. Our patient, I conveniently made, weigh 100 kilograms. So in total, I'll rewrite our equation down here, but our estimated blood volume is going to be 60 milliliters per kilogram times 100 kilograms equals 6,000 milliliters or 6 liters. That's the estimated total blood volume of the patient. Now we have the finding this variable, the hemoglobin of the patient. I said he has an initial hemoglobin of 15. And then we're determining, using our clinical judgment, what the minimum acceptable hemoglobin is. For the sake of convenience, and to make this problem easier to solve, we'll say that we want to have a more liberal transfusion policy. We're going to transfuse him when he's at a hemoglobin of 10. Generally, that would be a little bit lower, especially if he wasn't so high risk for ischemia or continued bleeding. And then we're dividing by the hemoglobin of the patient, which is 15. This right here is going to end up solving to 5 over 15, which equals 6 liters times 1/3. So we would transfuse this patient after he had lost 2 liters of blood. I hope that helps.